Okay, good afternoon. Today we will continue dealing with the skeletal system. I would like to remind you that we started the skeletal system last week. We dealt with the histology of bone and cartilage, and then we moved to gross anatomy of the skeleton, and we said that the skeleton is in two parts. It's the axial skeleton, which we dealt with, and the appendicular skeleton, which is the subject of today's lecture. So today we are going to deal with the appendicular skeleton. Again, I would like to remind you that there is a video, virtual lab anatomy video on the appendicular skeleton, and this is also related to a self-assessment PowerPoint file. You don't need to submit the self-assessment files. These virtual lab videos are for you to take notes, to study, to prepare yourself for the lab test in the midterm. So what are the components of the appendicular skeleton? These are the structures that are not obviously involved in the axial skeleton. So it includes the pectoral girdle and the bones of the upper limb, and the pelvic girdle and the bones of the lower limb. Let's start with the pectoral girdle or the shoulder girdle. By the way, the pectoral girdle indicates this area. This region is called the pectoral region, which is the chest area. It connects the upper limb to the axial skeleton, consists of two bones. It consists of the clavicle here and the scapula. And as you can see here, that the upper limb is connected to the scapula of the pectoral girdle through a joint, which is between the humerus and the scapula, glenoid cavity of the scapula. It's called the glenohumeral joint or the shoulder joint. We're going to talk about this joint in much more detail. And as you can see here, that the pectoral girdle, unlike the pelvic girdle, which we are going to talk about in a moment, that the pectoral girdle is not connected to the vertebral column. So you can see here that the scapula is held in position by muscles. It is not articulating with the vertebral column like the hip bone articulates with the sacrum, the vertebral column, part of the vertebral column. And also you can note here that it is only the clavicle that articulates with the axial skeleton. It articulates with the sternum at a joint which is called the sternoclavicular joint. And this is a very small articulation. You can expect that. We don't need a big articulation like the one that we have in the lower limb, because here this type of articulation gives more freedom of movement to the upper limb. We don't need this freedom in the lower limb. On the contrary, we need more stability and more structures that can withstand forces. So that's why the size of the articulations and the areas of articulation between the lower limb and the axial skeleton are much more wider than those of the upper limb. Now we start with the clavicle. Again, I mentioned that it's part of the pectoral girdle. So the clavicle, it articulates with the sternum, as I said. By the way, the clavicle means key, clay clavicle. And it's the other name is the collarbone. It looks like an old key, the shape of the old key. That's why they call it the clavicle. And this is the articulation between the clavicle and the sternum. I've just mentioned that it's at the sternoclavicular joint. And the clavicle, on the other hand, it articulates with the scapula at another joint, which is called the acromioclavicular joint. This is a process in the scapula. I'm going to talk about it in a moment. It's called the acromion process. So it's the humerus articulates with the scapula, and then the scapula articulates with the clavicle, and then the clavicle articulates with the axial skeleton, the sternum. And by the way, the wishbone of the birds is fused clavicles of the birds. The scapula, the other name, is called the shoulder blade. And it is obviously a flat bone, triangular in shape. If you look at it from the posterior side, you'll see that it has like a shelf or a projection, which is called, or a ridge, which is called the spine of the scapula. And this spine, if we follow it laterally, it will form a process, one of the processes of the scapula, called the acromion process of the scapula. It is the acromion process of the scapula that articulates with the clavicle at the acromioclavicular joint. So if you feel the tip of the shoulder, by the way, you are feeling the acromion process of the scapula. You will not be able to feel the lateral end of the clavicle, because the lateral end of the clavicle, or let's say the lateral end of the clavicle, does not form the tip of the shoulder, the bone that you feel at the tip of the shoulder, because the lateral end of the clavicle here articulates with the acromion, and you will be feeling the acromion if you touch your shoulder from this side, okay? And the posterior surface of the scapula will be therefore divided into a fossa. A fossa means depression. A fossa which is above the spine, so it's called the supraspinous fossa, and another fossa below the spine, and this is called infraspinous fossa. And these fossae are for the attachment of muscles, which fortunately have the same name. So we have supraspinatus muscle and infraspinatus muscle. And then the lateral angle here, we said that it is triangular in shape, so it has 3 angles. The lateral angle, as you can see it from this side, you can see that it has a smooth surface, which obviously it provides an articulation. It's called the glenoid cavity. It's called cavity, but it's very shallow, and this to give more freedom for the movement of the humerus. So it is at the glenoid cavity of the scapula that the scapula articulates with the humerus. Hence, the official name of the shoulder joint is the glenohumeral joint, because it's between the humerus and the glenoid process of the scapula. The scapula has another process which you can see anteriorly, and some of you might be able to feel it below the lateral end of the clavicle, and this is called the coracoid process. It's a little bit tapered, it looks like a crow's beak, and it's for attachment of muscles. I'm mentioning 2 of them because we are going to study these muscles later on. One of them, obviously, because it's attached to the coracoid process, so it's called coracobrachialis, because it extends to be attached to the bone of the brachium, which is the arm, the humerus. So that's why it's called coracobrachialis muscle. And the other muscle which you are familiar with is the biceps muscle, which, as the name indicates, biceps means that it has 2 heads. So one of the heads of biceps, which is called the short head of biceps, is attached to the coracoid process. And here we don't have a spine anteriorly, so there is a very big fossa called the subscapular fossa. Again, this fossa is for the attachment of a muscle, which again, fortunately, has the same name of the fossa, so it's called subscapularis muscle. So far about the pectoral girdle. We'll deal with the bones of the upper limb. So there are a lot of bones in the, whether in the upper limb or lower limb, usually there are 30. So there's the humerus, which is the bone of the arm, and there is the radius and ulna, which are the bones of the forearm. The radius is the lateral one, and in the hand we have the carpals on the wrist, and then the metacarpals and the phalanges. There are so many, a lot of joints, but the most important, we have the shoulder, the elbow, there is the wrist joint, and there are the metacarpophalangeal joints here, which form the joints of the knuckles. We're going to talk about them, and the interphalangeal joints. Let's start with the humerus. The humerus is the bone of the arm, the brachium, the region between the shoulder and the elbow. Remember the first lecture. So we should be very careful. The arm is only this area, while distal to that, it's the forearm. The head is the proximal end. So it's a long bone. That's why it has a distended end proximally and distally. Proximally, it's called the head, and this articulates with the glenoid fossa and a joint, which has the shape of a ball and socket. I'm going to talk about the shapes of joints next time when we deal with the articulations. So it's a ball and socket joint, glenohumeral joint. And then distally, there are condyles here, which articulate. The lateral condyle articulates with the radius, and the medial condyle articulates with the ulna. And obviously, since we have condyles here, there are prominent parts of bone above the condyles, and these are called epicondyles, above condyles. And the most prominent one is the medial epicondyle. You are able to feel your medial epicondyle. It is very prominent. It's on the medial side of the elbow. And if you roll your finger against the bone, you will feel that funny sensation, that like electrical stimulus, as if. And this is because you are rolling a nerve, which is called the ulnar nerve. Okay? So because of that funny sensation, the pun is sometimes used for the humerus as the funny bone. Actually, it is the medial epicondyle of the humerus that makes it funny. The bones of the forearm, we have the medial and lateral one. The lateral is the radius, and the medial is the ulna. And you can see here, obviously, that proximal end of the ulna looks wrench-like. So it looks like the U shape or wrench-like. And this will help you to differentiate the radius from the ulna. And also, this will give you an indication that although both of them participate in the formation of the elbow joint, but because of the wrench-like shape of the proximal end of the ulna, then the ulna will not be able to rotate around itself, while the radius has a flattened discoid head proximally, so it is the bone that can rotate around itself in the movement of pronation and supination. So these bones, they articulate with each other. So there is one articulation here, which is a fibrous type of articulation through a fibrous tissue called interosseous membrane. The name indicates the location. Inter means between, os means bone. So it's the membrane between the two bones, provide attachment for the two bones, and at the same time it provides muscle attachment. But the movement mainly takes place at what we call the proximal, remember these terms, proximal and distal radio-ulnar joints. These are synovial joints that allow rotation. But which bone is going to rotate? It is the radius. The ulna cannot rotate, and so rotation of the radius produce a movement that is unique for these joints. It's the movement of pronation and supination. This was mentioned in the first lecture when we mentioned in the anatomical position, we said the forearm is supinated. In other words, the palm faces forward. You use supination when you tighten a screw, okay? Or when you start up the engine of the car, you use the supination. Opposite to that is pronation. The movement is at the proximal and distal radio-ulnar joint. It is not at the shoulder joint. Now I'm fixing my shoulder and still I can pronate and supinate. Sometimes it might be confusing if you extend your elbow and do pronation and supination. You might think that the movement is there in the shoulder, but no, it is the movement at the proximal and distal radio-ulnar joint, and it is one bone that is rotating on the other. Obviously, this one cannot rotate because of its wrench shape of its proximal end. Now we have the carpal bones. These are small bones. They are short bones, according to the types of bones that you have studied: long, short, flat, sesamoid, and so on. So these are short bones. They are 8 in number, and they are in 2 rows. When the bones articulate with each other, they form like a groove, so a bony groove, and this groove is bridged or covered or roofed by a very thick connective tissue called the flexor retinaculum, because it's located on the flexor side of the wrist. So it is the flexor retinaculum, and this will make a tunnel. So therefore, the groove of the bones and the fibrous tissue will make a tunnel. Through this tunnel passes a lot of tendons, the tendons of muscles of the forearm that move your fingers. So these tendons are crowded here in a very tight compartment. So, but unfortunately, in addition to these tendons, we have a nerve, which is called the median nerve, that also passes through this tunnel. Other nerves and vessels, they pass superficial. They are not trapped in the tunnel. And the problem here is that any inflammation in these tendons cannot be compensated by enlargement of the tunnel, because the tunnel is made of connective tissue, thick connective tissue, and bone, so it cannot enlarge, and that's why this results in compression on the nerve and result in a syndrome which is called carpal tunnel syndrome, compression of the median nerve. The median nerve supplies some of the skin of the hand, so the patient with carpal tunnel syndrome will have like pins and needles sensation or tingling sensation in the hand. In addition to that, there will be weakness in the movements of the thumb. The thumb has small muscles that move the thumb, so the movements of the thumb will be weak, especially one movement of the thumb, which we are going to talk about it next time, is called opposition, is when you bring the pad of the thumb opposite to the pads of other fingers. This is a very important movement, but we are probably unaware of it, but we use it in many of our manual work. So this will result in weakness in this movement. This carpal tunnel syndrome used to affect probably people who do knitting, for example, before, but nowadays it's affecting more and more people who are using the keyboard a lot. So results in friction and inflammation of these tendons and pressure on the median nerve. Carpal tunnel syndrome, as the median nerve passes through the carpal tunnel. Then we have the metacarpal bones and the phalanges. The metacarpals are 5 bones. Again, they are long bones because they have a base, distended, and then body or shaft and a head, and they are numbered from lateral to medial. So the lateral is the one for the thumb, and the medial is number 5. And the head, they articulate with the base of the proximal phalanx at the metacarpophalangeal joint. The metacarpophalangeal joints are the joints of the knuckles here. Okay, and then we have the phalanges. We have 3 phalanges in each of the medial 4 digits, 1, 2, and 3, proximal, middle, and distal phalanx. They are long bones in the sense that they have a base, shaft, and distended head, except here in the thumb we have 2 phalanges. So all in all, we have 3 times 4 plus 2 equal 14 bones, the phalanges. The joints between them are called interphalangeal joints. So this is a proximal interphalangeal, this is a distal interphalangeal joint. But this one is between the proximal phalanx and the metacarpal, so it's called metacarpophalangeal. In the thumb, because we have 2 phalanges, then obviously we only have 1 interphalangeal joint because they are 2 phalanges only. So far about the upper limb and the shoulder girdle. Let's deal with the pelvic girdle or the hip girdle. And this is formed of 2 hip bones or the pelvic bones. But these, they articulate posteriorly with the sacrum. Remember I mentioned that the shoulder girdle does not articulate with the vertebral column, but is connected to it by muscles to provide more freedom of movement. Here, the pelvic girdle is attached to the vertebral column, the part of the vertebral column which is the sacrum, and the joint is called the sacroiliac joint. Iliac because this bone, the hip bone, is in fact formed of 3 bones. It is the ilium, pubis, and the ischium. And it is the ilium part of the hip bone that articulates with the sacrum at the sacroiliac joint. These bones, they were separate from each other in the newborn and in young people, as you can see here, that there are plates of cartilage separating in between them, and they meet together at a depression here, a very big depression, which is called the acetabulum. And this acetabulum is a socket for the head of the femur. You can compare this depression to the glenoid fossa of the scapula, and you will find that the glenoid fossa is shallow, while this one is deep. Okay, so this one provides more stability for the lower limb. We don't need that stability for the upper limb. And on the contrary, we need more freedom for the movements of the upper limb. That's why the glenoid fossa is shallow. It's not deep like the acetabulum. This hip bone or pelvic girdle supports the vertebral column and supports pelvic and lower abdominal organs. And it transfers forces from the lower limb, because the femur articulates at the acetabulum, so the forces are transmitted to the vertebral column. Now we'll start with the first one, the ilium. The ilium is I-L-I-U-M because we have another ilium in the body, I-L-E-U-M, and this is part of the small intestine. And we will study that with the digestive system. The small intestine consists of the duodenum, jejunum, and ilium with E. This one is with I. It is the superior part of the hip bone. It is flat and has a crest of bone here that we can all feel in the waist. It articulates with the sacrum, as I mentioned, at the sacroiliac joint, and it has a notch. This is a notch of bone called the greater sciatic notch. So this greater sciatic notch, it transmits it's the biggest nerve in the body, in fact, which is called the sciatic nerve. We are going to study that nerve later on. The sciatic nerve, biggest nerve in the body. Of course, it's not only the sciatic nerve, but there are other nerves, vessels, and even a muscle passes through the greater sciatic notch. Now, this bone, just to remind you, it's a flat bone, so you expect that it contains bone marrow, red bone marrow, easily accessible because you can feel it under the skin. So that's why it's a good site for taking either bone marrow biopsy, or even they can take part of the bone, which is called bone grafting. They call it autograft. If there's a fracture in the body somewhere else with loss of a lot of bone, that the two remaining bones, there will be a very big gap in between them, and they cannot produce enough bone to fuse them together, then they will use what we call a bone graft. They will bring bone from somewhere else. This is one of the good sites to bring bone from, and put it in the space in order to encourage and stimulate bone formation, further bone formation, and so the two fragments will fuse together again. So this is called bone grafting. The ischium is located posteriorly and inferiorly. It has a lesser sciatic notch, but more important, it has a big tuberosity, a very rough piece of bone. And this is, again, this is the bone that we sit on and annoys us if we sit on hard surfaces. That's the ischial tuberosity, as well as it provides for muscle attachment. The muscles of the back of the thigh, the hamstring muscles, are attached to it. We're going to deal with the hamstring muscles in the last lecture of this block. And then we have the pubis, which is the anterior inferior part of the hip bone, and as you can see here, it has a ramus, a superior ramus that fuses with the ilium, and fuses by an inferior ramus with the ischium, and it has an articular surface here. It's called the pubic symphysis. This is a symphysis. There's a fibrocartilage here uniting the two bones, the two pubic bones, and there is a very big foramen here, which is called obturator foramen. Obturator means closed. This is the literal meaning of the word, because in life, although this foramen is so big, but it is in fact closed by fibrous tissue, except for a very small area that allows for the passage of a nerve and vessel which carries the same name, obturator, nerve, and vessels. So we were talking about the hip bone. We said that it is of three parts, ilium, pubis, and ischium. This will lead us to the bony pelvis. The bony pelvis, these two hip bones, which constitute the pelvic girdle, when they articulate with the sacrum and coccyx are part of the vertebral column, so they will produce a bony pelvis. And this pelvis has two parts. A part which is false, because it belongs to the abdominal cavity. So it is this part of which is bounded mainly by the ilium. This is called the false pelvis. Okay, it's part of the abdominal cavity. That's why I mentioned that the hip bone provides protection for abdominal viscera, some abdominal viscera, as well as the pelvic viscera. It's the false pelvis part of it that provides part of abdominal viscera. Now, the true pelvis, it lies below this area, below this line, which is called the pelvic brim, or the other name for the pelvic brim, it's called the superior pelvic aperture, or the pelvic inlet, because the other one, which is located below here, this one, it's called the inferior pelvic aperture or the pelvic outlet. They are called inlet and outlet according, just to, in order not to confuse them, according to the route taken by the fetus or the presenting part of the fetus during delivery. So this one will be the inlet and this will be the outlet of the pelvis. So when we talk about the pelvis, we mean the true pelvis, the small lower part, which looks like a basin. That's the pelvis. That's the true pelvis that holds the reproductive organs, urinary bladder, and the distal end of the alimentary canal, the rectum, and part of the sigmoid colon. And it extends from inlet above to pelvic outlet below. In the pelvis, this is one of the bones that can help in differentiating sexes. Like if you find a piece of bone, especially for anthropologists or for medical legal purposes, the hip bones are useful in that respect. The reason is that in the male, the pelvis is heavier, it has larger articular surfaces and more prominent landmarks for muscle attachment, which conforms with the heavier built and stronger muscles in the male. And this is general for all bones. But for the pelvis in specific, the pelvis is longer and narrower. If you compare it with the female pelvis, that will be smooth, obviously, more smooth than the male pelvis. But the most important is that the female pelvis, to allow for childbearing and childbirth, it will be wider and shallower than the male pelvis. And of course, there are so many features that can be tested, but one of the most obvious and most important feature that I would like you to keep in mind is the shape of this pubic angle or pubic arch, what we call it. So this pubic angle or pubic arch in the female, it is greater than 90 because the pelvis is wider, while it is less than 90 in the male. Sometimes they say that this one looks like a Roman arch, while this one looks like a Gothic arch. Or, again, to remember them, is that in the female, the angle is the same like the angle between the thumb and index finger, while in the male, it is the angle between the index and middle finger. Okay? And the reason, as I mentioned, is that the female pelvis should be wider and shallower to provide for childbearing and childbirth. If it is not like that, then we might have some problems during delivery. I mean, normal vaginal delivery. The lower extremity, again, has 30 bones. It has the thigh, which contains the femur, the bone of the thigh, and the patella, the sesamoid bone. Tibia and fibula, like in the forearm. There in the leg, we have the tibia, the medial bone, and the fibula, the lateral bone. And in the foot, we have the tarsals as opposed to carpals, metatarsals as opposed to metacarpals, and phalanges, which are the same. And the joints are the hip, knee, and ankle. Of course, these are not the only joints, but the joints that we're going to focus on mainly. The femur is the longest bone in the body. Actually, the length of the femur, it's a long bone, and it is the longest bone in the body. Actually, the length of the femur is 1/4 of the height of its owner. So again, this can be used for probably medical legal purposes. And as I said, it's a long bone, so it has a distended upper extremity and or a proximal end and a distended lower end because of its length. And many anatomists use it as a selfie stick. I'm just joking. If they want to have a selfie inside the lab, so it's long, so indicating that it can be used as a selfie stick. The proximal end has a head which articulates with the acetabulum. I have just mentioned that the head fits well into the deep acetabulum to form the hip joint, and it has a neck. This is actually a very important part of the bone. This neck is a narrow part that is a site of fracture, easily fractured, especially in the elderly and elderly women because of osteoporosis that they suffer from after menopause. So any minor trip, any minor fall might result in fracture of the neck of the femur. The problem here is that the head of the femur receives most of its blood supply from the area distal to the neck. So the blood comes from here, from this region. So if the neck is broken, then this will endanger the blood supply of the head of the femur and results in death of the head of the femur. We call it avascular necrosis of the head of the femur. That's why, especially in the elderly people and in certain types of fracture, they don't treat the fracture conservatively. They have to replace, because at the end there will be death of the head of the femur. So they replace it with a prosthesis because of this danger. It is one of the common fractures in elderly women, fracture of the neck of the femur. And it has prominences which are called the greater and lesser trochanter. There are no other prominences in the body called trochanters, but we have to call it trochanter. I don't know why they didn't call it tubercle or tuberosity, but they call it trochanter. Greater and lesser trochanters, and it is the greater trochanter is the bone that annoys you when you lie on your side on a hard surface. That will be the greater trochanter of the femur, and distally, obviously, it articulates with the tibia. It does not articulate with the fibula, and anterior part of the distal end articulates with the patella. You can see here that the fibula does not participate in the formation of the knee joint. The knee joint is an articulation between the femur and the tibia and the femur and the patella. But there is no involvement of the fibula, which means that the fibula is not a weight-bearing bone. The weight of the body, the force of the weight of the body will pass from the vertebral column to the hip bones, to the femur, and then down through the tibia. It does not go through the fibula. The fibula is not a weight-bearing bone. This is the patella or the kneecap. I mentioned about it like it's a sesamoid bone. It's present in the tendon of the quadriceps femoris muscle. And it's like any other sesamoid bone. It increases the leverage of pull of the muscle in whose tendon it is located, and also reduces the friction between the tendon and bone. The tibia is the medial bone, is the larger bone of the leg, and is the weight-bearing bone. It has condyles, like the condyles of the femur. It has condyles that articulate with the femur, and it has a tuberosity anteriorly. You can feel your tuberosity, a big tuberosity. It is the bone that we kneel on, is the tibial tuberosity. And like the radius and ulna in the forearm, these tibia and fibula, they are connected to each other by another interosseous membrane. But in addition to that, they are also connected by joints. So we have a proximal tibiofibular joint and a distal tibiofibular joint. And on the medial side, the tibia has a prominent bony landmark, which again, you can feel, you can hit on the medial side of your ankle. This is called the medial malleolus. Malleolus means hammer. So it looks like a hammer, so that's why they call it the malleolus. They call it medial malleolus because the fibula has another malleolus here, which is called the lateral malleolus. So these two malleoli, they form like a socket for the ankle joint, for the talus to form the ankle joint. So distally, as you can see here, distally, tibia articulates with the talus. The talus is one of the tarsal bones and articulates with the fibula as well. So the tibia articulates with the femur, articulates with the talus, and articulates with the fibula. Now the fibula does not articulate with the femur, it's non-weight-bearing bone. It serves for muscle attachment. Because it's not a weight-bearing bone, then it is another site, a preferred site to take a bone graft. So they can take part of the fibula and use it in another place as a bone graft, and this will not affect in the walking of the of the person. Walking and jumping can be normal. The fibula articulates with the talus and the tibia and expands to form the lateral malleolus. The tarsal bones are the proximal region of the foot. We have 7 of them, as opposed to 8 carpal bones. We have 7 tarsal bones. You don't need to memorize the names of all bones, but one of them is the talus, which has been mentioned several times. It is the bone that articulates with the tibia and fibula at the ankle joint. And then the other one is the bone that is the bone of the heel, which is called the calcaneus. So the calcaneus is the bone of the heel. It does not articulate with the tibia, does not articulate with the fibula. Then we have the arches of the foot. These are bony arches of the foot. So we have 2 longitudinal arches, as you can see them here. This is one lateral, medial, and then the lateral longitudinal arch, and then we have the transverse arch. If you look at your wet footsteps on the floor, you will find probably only one arch, which is the medial longitudinal arch. The reason is that when we talk about these arches, we are talking about the bony arches. And the medial longitudinal arch is the deeper arch. These arches, the bony arches, are covered with skin and a pad of subcutaneous tissue. So when you step on the floor with a wet foot, you will not be able to see them, but you will be able to see only the most or the deepest one, which is the medial longitudinal arch. But there are 2 longitudinal arches and 1 transverse arch. Why do we have these arches? Obviously, they distribute the body weight, as you can see it here. They distribute it 60% posteriorly at the calcaneus and 40% at the heads of the metatarsals. And if this proportion is disrupted, as when women wear high heels for a long period of time, this will cause like 80% of the body weight going to the tip of the metacarpal bones, which will produce a lot of problems and symptoms, whether in the bone or in the underlying skin or overlying skin, let's say. And the second reason for these arches is that they act like springs or shock absorbers when we walk, and they are very important for adapting our feet to walking on uneven surfaces.